to selecting the right anticoagulant in the complex patient. In previous sessions of the VTE Heartbeat series, we provided an overview of VTE, discussed specific assessments and considerations for patients with VTE, as well as selecting the right anticoagulant for a patient with VTE. Today, we're going to cover VTE treatment selection in complex patient populations. In the general population, up to 900,000 people in the US are affected by venous thromboembolism every year. In these types of complex patient populations, timely and efficacious treatment for VTE is essential to optimize health outcomes and reduce the risk of VTE recurrence. As we get started, I want to mention that this series is supported by an educational grant from the Bristol Myers Squibb and Pfizer Alliance. Recommendations and opinions presented may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by AHA. The AHA does not endorse any product or device. I'm Dr. Erica Shore, Associate Professor and Chair of the Adult and Gerontological Health Cooperative at the School of Nursing at the University of Minnesota. And joining me today is a distinguished multidisciplinary panel.
I'm Tara Leck. I'm a clinical pharmacist and director of anticoagulation services and stewardship for Beth Israel Lahey Health in Massachusetts.
I'm Arthur Allen, an anticoagulation specialist, our program manager and a clinical pharmacy specialist at the VA hospital in Salt Lake City, Utah.
I'm Jeffrey Barnes. I'm a cardiologist and vascular medicine specialist at the University of Michigan.
Thank you all for joining me today. Let's start with how the VTE location may impact treatment decisions. Direct-acting oral anticoagulants, DOACs, have emerged as first-line therapy for patients with acute DVT and/or PE. Arthur, why is this the case?
Well, I mean, the option that we've had prior to DOACs involved sharp, pointy objects for starters, right? So we had to use either heparin lead-in therapy with warfarin back in the day, or then injectable lead-in with low molecular weight heparin. And warfarin, of course, brings with it what warfarin is an odd drug that requires a narrow therapeutic window drug that requires therapeutic monitoring. And DOACs behave themselves more like drugs are supposed to. You put the pill in your mouth and swallow it, and it does its job, and it has relatively fixed dosing. And so they, for that reason, really kind of emerged. And not to mention the efficacy and safety data from the trial, they're at least as good as warfarin, probably better, and certainly safer than warfarin.
What makes them preferred over vitamin K antagonists and low molecular weight heparin for most patients with VTE?
Yeah, I mean, so all four of the DOACs have an indication for VTE. Two of them within the way they did their studies resulted in labeling that still required injectable lead-in therapy. The other two used higher doses of their medication. So rivaroxaban and apixaban used, we call it loading dose. It's not really, it's more of a higher intensity anticoagulation up front for either a week or 21 days, depending on the agent chosen. And it allows you to stick with a single agent oral medication that can be used in the very acute phase, in the kind of the first 3 months maintenance phase, and then for secondary prevention as well, if you maintain long-term therapy. And the other advantage for the secondary prevention phase is that both apixaban and rivaroxaban did extension trials that allowed for the option of step-down dosing, essentially to the prophylactic dosing of those agents for secondary prevention in most patients.
There are some patients for whom it has not always been clear which anticoagulant is best to treat acute DVT or PE. Let's talk through a few of those scenarios. Tara, what about patients with obesity? Can we still use DOACs even if the patient has severe obesity?
Yeah, so I think that's a great question and something that's really been evolving over time. It's been really interesting to watch, when DOACs first came to market and the landmark trials, had patients that were typically 80 plus or minus, 10 kilos here or there. So we felt comfortable using DOACs for VTE in patients that had a weight, around 120 kilos or less, BMI of 40 or less. And that's really where, in 2016, the ISTH came out and gave guidance to clinicians to say, DOACs are safe, and effective in this lower body weight, lower BMI population, and left a lot of us saying, well, what do we do with this other cohort of patients that exceed 120 kilos and have a BMI greater than 40? Are they have to be on warfarin because we don't know? Or, should we start to look at this? And knowing that DOACs have a very wide, therapeutic index, it was, people using these drugs in the obese patient population and then studying them, that was really important to move the needle. So when we started to look at retrospective data, small prospective studies, meta-analyses, we started to see what really took shape was that apixaban and rivaroxaban, of all of the DOACs, appeared to maintain their safety and efficacy in patients even above weights of 120 kilos or BMIs greater than 40. So this started to lead clinicians to be able to open the door to these patients and have those, really important shared decision-making conversations to say, we do have this option. You don't necessarily have to be on warfarin. We encourage lifestyle, changes and, healthy habits, but also you can be on a DOAC and still be treated for your VTE. But I think as, we continue to move the needle, we always have to stop and pause to see where the gaps still exist. And so when we do take a look, we can see that when we get towards even more extremes of weight, weights greater than 150 kilos, BMIs greater than 50, we still don't have a lot of data in that space. So it's important to talk to your patients to think about what you're doing, because really what we're worried about at the higher BMIs and higher weights is that we're not going to reach the peak levels that we need to maintain efficacy. And so I think it's just important to continue to evaluate this process and know that this might be a role where you really do have to talk to your patient about what is best for them, to see if there are other ways to check to make sure that they are getting appropriate DOAC levels in those patients. And then the other converse of that too, when you get into the extremes of body weight, you need to think about, has my patient had, or are they going to have gastric surgery? So if they've had bypass, we have to think about the differences that might happen with their absorption of these drugs. So in the acute phase after surgery, we don't want to use DOACs, especially within those first 4 weeks. And then later we can have conversations about maybe using DOACs in those patients later on, but always keeping in mind that we don't always know about the absorption, and especially in surgeries like Roux-en-Y, gastric bypass, there may be alterations in absorption for these patients. And then the same thing goes for, the extended duration treatment for these patients. We have a lot of good data with standard dosing of DOACs in obese population, but we haven't really delved into using that reduced dose long-term and knowing if that's just as efficacious for these patients.
Great points, Tara. Another population of concern is patients with chronic kidney disease. Jeff, what is your current practice?
It's really important to consider somebody's renal clearance when we're thinking about selecting the appropriate anticoagulant. And that's because all of the DOACs are at least in part cleared by the renal system. Now, some are more renally cleared than others, so that helps us think about which agents may be more or less appropriate for somebody who has chronic kidney disease. For me in practice, I feel very comfortable using any of the DOACs in patients who have moderate levels of chronic kidney disease. It's when you get to that severe level where things start to get a little bit more concerned. So I'm talking about a creatinine clearance of less than 30. That's where I start to get a little bit more concerned about, is it safe to use a DOAC or not? Now, if you look at the FDA label, some of the DOACs indicate that it may be okay to use, but they very clearly highlight that there's very limited data, and that below a certain threshold, for some studies it was 30, for others it was 15, a creatinine clearance of less than 30 or 15, those patients were excluded from the clinical trial. So you kind of have to go outside of clinical trial data if you're going to use a DOAC in a patient who has very severe chronic kidney disease, such as a creatinine clearance of less than 15 or on dialysis and they have a VTE event.
So do you feel comfortable using DOACs in a patient with chronic kidney disease who is diagnosed with end-stage renal disease? And if not, what would the alternatives be?
For me, that's a really great opportunity to have a good discussion with the patient so that they understand the potential risks that they are exposed to. I will sometimes use some of our direct oral anticoagulants, in particular apixaban, because it has the lowest level of renal clearance in a patient who's on dialysis for end-stage renal disease. But I make it very clear to the patient that these drugs have not been tested in that population. We're sort of extrapolating from some of the AFib literature. Also, I personally don't tend to use that initial 7-day higher dose in those patients because of some concerns about accumulation. I tend to stick to more of the parenteral agents during that initial phase and then transition over to the standard dose of apixaban, 5 milligrams twice a day for treatment of VTE in that population. Occasionally, we'll use rivaroxaban because a patient really wants once-a-day dosing, but I make sure that they're aware that it has a slightly higher amount of renal clearance dependency, and so we're at higher risk of accumulation of that particular drug. So that's when we start talking about whether warfarin might be a better option or not. Again, this has to be personalized, important shared decision-making opportunity.
That's helpful information, Jeff. Arthur, another high-risk population is individuals with cancer. What is the current practice of anticoagulation selection for a patient with cancer-associated thrombosis?
Yeah, great question. So cancer, we should first of all recognize that cancer is extremely provocative for DVT. It's the most provocative cause of DVT that I would personally consider an acquired thrombophilia. It's the most common acquired thrombophilia. That's how I like to think about it. And historically, since the early 2000s, low molecular weight heparin has actually been preferred, although the actual uptake of using low molecular weight heparins, as opposed to warfarin, when those were the only options, it took a long time for that to actually happen. What we do know is that warfarin is kind of a terrible drug in cancer patients. They have terrible time in therapeutic range. Former VA researcher and colleague of mine, Adam Rose, did a study that basically just said that warfarin's a terrible patient in cancer patients, or a terrible drug in cancer patients. What we needed to know were the DOACs okay? And a lot of folks went ahead and used DOACs in that setting, kind of and anticipating and extrapolating. But we finally, several years ago, had cancer-associated VTE DOAC trials compared to the right drug, dalteparin, which was approved in low molecular weight heparin in cancer-associated patients, and found that it was a non-inferior option. In fact, if you look at those studies, you'll see that numerically more patients had breakthrough clots off of low molecular weight heparin. It did bring up some concerns about higher risk of bleeding in the DOAC population, particularly in patients with GI luminal tumors, as well as GU tumors. There was some concern about higher rates of bleeding, especially in the earlier trials, driven by those types of bleeds. And so there's still some question about, in those particular types of situations, should we favor low molecular weight heparin? I think that shared decision-making is a reasonable approach in those options, but certainly I now consider DOACs to be the preferred agent for cancer-associated VTE for most patients, with some shared decision-making perhaps around some of those higher bleed risk patients.
Thanks, Arthur. That's helpful to think about some of those specific situations. What about drug-drug interactions? We know there are a lot of interactions with warfarin, but what about with DOACs? Tara, what are some drug-drug interactions that you look for to ensure that a DOAC is being used safely?
Yeah, no, drug interactions are always everyone's favorite topic. I know everyone loves to think about cytochrome P450, peak glycoprotein, and keep all those lists straight. I think the important thing to know is that even though we don't have as many interactions as warfarin does, the DOACs do have some pretty significant interactions. But what I can say in my practice is that I try to keep it simple. It's important, if you know a pharmacist, to make good friends with them because they can help you, to know your resources. Like the AC Forum has a fantastic rapid resource that focuses explicitly on drug interactions. And then if you are on your own and having to make these decisions, I try to think about the ABCs. So my A's are, my antifungals, like my ketoconazoles, my antiarrhythmics, like dronedarone, anti-seizure meds, like carbamazepine, or antimicrobials, like rifampin, and go through that list of heavy hitters where, whether it's DOAC or not, these medications are likely to have some sort of interaction. And so screening the list And then B, thinking about any meds that's going to potentiate bleeding risk. So is my patient on aspirin? Are they on NSAIDs? Do they have P2Y12? Am I getting into a triple therapy situation? And then considering the C's. So other considerations like the renal function, hepatic function, age, body weight, things that are going to potentiate these drug interactions, and then trying to put that all together. Because I think the important thing is that there are always a lot of interactions we talk about major that are going to significantly impact the concentration of the drug and either put a patient at risk of, too high of a level and bleeding or too low of a level and having an embolic event. But then there are a lot of these moderate interactions that no one really knows what to do with. And sometimes that's a good thing because you're apt to not touch it, because there's a big difference between a pharmacokinetic interaction and like a clinically significant interaction. And what can make the difference between a pharmacokinetic interaction that I can let go and a clinically significant interaction are going to be these other risk factors. Like I have one moderate interaction that's probably okay if the patient is otherwise healthy, good renal function. But when I start to add in other interactions and having, 2 or 3 moderate interactions, or that's when we really have to be discerning about aspirin use in these patients. These are the things that are going to predispose patients to adverse events.
If I could just jump in there just real quick and point out that warfarin, there is no really contraindicated drug. I mean, if for pharmacokinetic speaking, NSAID we shouldn't be using, but we can work around them with the dose. Rifampin might make you require 4 times more warfarin, but you can still use it. Whereas with the DOACs, it simply becomes a no-go with some of these interactions. The other thing I point out real briefly is that in the labeling, you'll find some suggestion on these drug interactions that require a dose adjustment of the DOAC. Just know that all of that is made up. That's all, with the exception of edoxaban, which did actually include some drug interactions as part of their dosing in their trials. Everything else is made up. It's all based on pharmacokinetic modeling. It is in the label, but it's not based on actual clinical science or experience.
Great points. Thank you both. Jeff, taking a step back, thinking about how do you start to compare the different DOACs in general?
Yeah, I think this is a really good question because everything we've talked about are some of the nuances of prescribing these drugs, especially in more complex patients. But as I take a step back and I think about the general patient with DVT or PE, I think of 3 main things that I want to consider as I'm comparing the drugs. The first is, does this drug require parenteral lead-in or not? We know that warfarin, dabigatran, and edoxaban all require parenteral lead-in in a patient who has an acute DVT or PE. But apixaban and rivaroxaban do not. They can be used in an oral-only strategy. The second question I always ask myself is this a patient that needs once a day, or is this a patient who can tolerate twice-a-day dosing? Because the dosing of the different DOACs is different based on which one you're prescribing. Some of them use once-a-day dosing regimens. Some of them use twice-a-day dosing regimens. That might be important for an individual patient, especially around compliance issues. And then the third consideration is going to be, what are you going to do after that initial treatment phase? So when you get beyond the initial 3 to 6 months, is there an opportunity to lower the dose of the DOAC in sort of this secondary prevention or extended treatment phase? That option exists for both apixaban and rivaroxaban to use kind of a half dose, sort of a keep away any recurrent VTE option, or are you sort of sticking with the standard treatment doses indefinitely? So when you use those 3 questions, you can often get to the point of figuring out what might be the best drug for sort of a routine or the average patient with an acute DVT or PE.
Do you have a strong preference for one DOAC over another?
Absolutely not. I think it's really important that clinicians get comfortable with at least 2 different DOACs because you're going to need to have some flexibility. And so I tend to talk with my patients and I ask them certain questions like, are you able to take a twice-a-day medication reliably? Or is it really important for you that you only have to take your pill once a day? That's going to be a big decider for me. I need to make sure I'm comfortable with the different dosing regimens, especially as I think about renal function, so that I know how that's going to impact. And then, of course, you need to know what are some of the potential side effects. And a patient who may experience bleeding with one drug may not with a different, or they may end up with some sort of unusual side effect with one drug that then you switch to a different one and they don't have. So I don't have a single drug that I prefer. I tend to use at least 2 drugs most of the time. And then if I need to go to a third or a fourth line agent, that's where I'm really going to start looking up the details and figuring out the dosing strategies. But I have 2 of them sort of ready to go at all times. And I talk with my patient about what's best for them.
Yeah, if I could just real briefly, people do tend to remember only apixaban and rivaroxaban. The bigger trend was the first DOAC on the market, and it has a different mechanism of action. So that is sometimes a tool in the toolbox that you might need to pull out for example, breakthrough thrombosis, or if you're questioning if there was a breakthrough thrombosis. And then edoxaban, though rarely used in this country, probably has the best drug interaction profile, and it allows you to get away with certain things with edoxaban that you may not feel comfortable getting away with other drugs. So I agree with Jeff that the 2, certainly having 2, but let's not remember that we do have niche, situations where we might apply the others.
Well, thank you all. This was an excellent discussion of the VTE treatments that currently exist, those treatments that are more common among complex patients, outlining some specific examples of a patient with chronic kidney disease, a patient with cancer, and a patient with obesity. We provided an overview of some key safety considerations and precautions for VTE treatment selection. I just want to thank all of our panelists today and the American Heart Association. This podcast series is available through all major podcast platforms. To claim credit, visit learn.heart.org.